Yeah. Hi, very good day. A
Hi,
very
very
good
good
day to
morning.
you. I'm Dr. Lee, the doctor in charge of General Medical Clinic today. So before I proceed, could I confirm your name and your age, please?
Yes, Dr. I'm Mrs. Napoleon Hill. I'm 65 years old.
All right. Thank you very much. So before I proceed, I'll need to ask you a few questions regarding what has brought you here today and also some questions of an intimate nature. Would that be fine with you?
Yeah, yes, Doctor. Thank you for coming.
Okay. All right. So could you please tell me in general what has brought you here to the clinic today?
Well, Doctor, for the last, 2 weeks, I was feeling sick. Okay, initially, I did not bother, but later on, when I stand in front of the mirror, I seems to be look yellowish. Okay, and in your language, it's called jaundice. I went to your GP, and GP said it could be something serious. And that's why he referred me to you for further evaluation. Please help me, doctor.
Okay, all right. So I'll just need to ask you a few more questions about the yellowing of your skin. So could you please tell me more about this yellowing that you noticed in the past 2 weeks? Was there anything else you noticed?
Uh, I don't think anything I noticed, but what I noticed, doctor, I'm not energetic as I was before. I would say I'm feeling generalized weakness, all of my
Okay.
body, not getting enough energy to do my household chores. So that
Um,
actually, brought my attention as, okay, what actually happened to me? And then I went to
okay.
the GP. GP think it could be something different. That's why he referred me to you.
Yes. All right. So just to recap, you're having this yellowing of the skin and also tiredness for the past 2 weeks. Is that correct?
Yeah, you're right.
Good. Okay, so I'll just need to ask you some questions. When you were having this yellowing of the skin, did you notice any stomach pain, any tummy pain?
You are right, doctor. Yeah, I have some, tummy pain, but not always. Yeah, you are
Okay.
right. There is some tummy pain. Yeah.
And could you show me exactly where the pain is? Is there a particular
Uh,
area
it's my, around my, belly button.
around the belly button?
Yeah.
Okay. And what do you think the pain feels like? Is it a gnawing kind of pain, a boring kind of pain,
It's
some twisting or piercing kind of pain? How would you
I
describe it?
it's a really boring type of pain, and sometimes it's cramped, doctor. And that time it's really unbearable. Yeah.
I Okay, so when we talk about unbearable pain, and if you were to give me a rating scale of maybe 1 to 10, where 1 is where the pain is still bearable and 10 where the pain is excruciatingly bad, how much would you rate your pain?
So right now I would say it's 3 or 4 in a boring manner,
Oh,
but sometimes it started cramping, and that time I feel seems to be around 7 or 8. Yeah.
okay. Is there any particular time where you notice the pain strikes?
Mm, no, not really.
Not really. How about when you're eating, like when, for example, if you're eating oily foods or fried chicken or fried foods, do you notice the pain becoming even worse than usual?
No, doctor. To be honest, I try to maintain healthy food. Okay, and for the
Yes.
last 2 days, anything I'm trying to take, it causing so much pain, and even I have to start in the morning. Okay, sometimes I have to miss the meeting due to that pain.
Okay. Did you notice the pain shifting anywhere? You know, sometimes the pain can shift around. Do you notice it shifting for your case?
Yeah, GP also asks the same questions, but I don't think it moves anywhere.
I see. Does the pain pierce all the way to the back?
No.
Nah. All right. So when you were, let's say, having this pain, were you also feeling nauseated? Like you felt like throwing up or vomiting?
No, not really. Only pain is
Yeah.
there. Yeah.
Okay. And how about this sense of itchiness all over the body? Were you having that too?
Yeah, you are right, doctor. I notice, particularly in the night times, for the last 1 week, my sleep is not well due to some 18 years.
I see. Just some questions, right? While you were having this yellowing and this tiredness, were you also having diarrhea? Were you having any
Uh,
diarrhea?
yeah, doctor. I noticed 4 or 5 times, I mean, loose motions. I have to visit toilet frequently for the last, I mean, 3 or 4 days. Yeah, you're
Yeah.
right.
And did you notice anything unusual about the color of the stool?
Mm, I mean, it looks like a water, and there is no change in the
Yes.
color. Yeah,
Yeah. Is it the kind of stool that floats that is difficult to flush down the toilet bowl?
to be honest, I didn't notice, but I
No.
will be aware of that.
Okay. Did you notice any blood or any slime in the stool?
No,
No. Okay. Was there any pain when you were trying to pass motion?
no, there's no pain during
No.
defecation. No.
Okay, good. And how about when you were passing urine? Did you notice anything unusual about the color?
I think my urine water wax is fine.
Mm-hmm. Did you notice any darkening of the urine?
Mm, no, no.
No. Okay. How has your appetite been in the past 2 weeks?
I would say it's fallen dramatically, doctor. I mean, I could not, I mean, feel any interest to take any food. And as a result, I'm getting weak day by day, doctor. Please help me.
I see. And did you notice your clothes becoming looser or your body felt, I mean, you've been losing weight in the past 2 weeks?
I did not, I mean, notice, but definitely it could be 1 or 2 kg, I mean, lower than my normal weight as I'm not taking any food, doctor. Yeah, that could be,
I
yes.
see. Okay, I do have a question to ask regarding fever. When you were having this yellowing of the skin and this loss of this tiredness, were you having fever as well?
Yes, doctor, you're right. And
Mhm.
you can check the, I mean, the vital chart. Yes, still I'm feeling feverish.
Okay, good. Uh, could you tell me more about this fever? Is it a fever that comes almost every day?
I would say it's always remain, but during
Yeah.
night time I feel more chills and I mean rigor. During that
Oh,
time I feel probably because of my busy schedules. And during
yes.
daytime I cannot feel it, doctor. Yeah.
Okay. I would just want to confirm something. Which one came first, the fever or the yellowing?
I've said fever first. Then I noticed
Yeah.
that yeah, there is some yearly discoloration of my body. Yeah.
Okay, all right. Okay, so I'm going to ask you some questions regarding your background, your family, and where you've been. Would that be okay?
Definitely, doctor, you can.
Okay, but before that, I'll just screen a few questions. Yeah. Do you have any shortness of breath right now?
No, I don't think so.
Okay. Any chest pain?
No.
Any sense of the heart racing very quickly?
Sorry. Any racing?
Any racing of the heart?
No, no, no.
No. Okay. Any joint pains in the hands or feet?
Yeah, I used to see, doctor. I mean, all over my body there's some pain, which was not
Pain.
there, by the way. It's completely new for me.
Okay. When did this happen? Did this happen before the yellowing of the skin or after?
I'd say it's for the same times. I mean, day started the fever, then followed by
Yes.
notice that 1 or 2 days later it started. All over my body's painful, doctor.
Ah, I see. Were you having muscle aches as well?
Yeah, probably because whenever I touch my belly muscle and a muscle of
Yeah,
my
it feels.
hands and legs, I
Yeah.
feel pain. Yeah.
Okay. All right. So, just to confirm, did you notice any loss of hair, massive loss of hair?
Mm, no,
No. Any ulcers in the mouth
rather, doctor,
recently?
I'm noticing some, I mean, growth of my hair, doctor. I mean,
Ah,
initially to fall, but right now it stopped falling.
I see. Okay. And how about any rashes? Did you notice any new rashes in the past 2 weeks?
No, there is no rashes.
No rashes. Any bleeding from the nose or from the mouth recently?
No, doctor.
No.
But I would
Any
like
pain?
to share one thing. Okay, there is no rash, but I have some thing to say to you. I underwent surgery, doctor.
Ah,
Yeah,
yes.
these are the healing rash, you can say. Yeah.
Okay, I see that you've undergone this surgery, but I'll ask you some questions about that later. Okay, so just to confirm with you, right? Did you notice any bleeding when you're passing motion?
No, I
No.
did not notice that.
Okay, none. Okay, so just to ask you a few questions about your previous medical health issues. Did you have any previous medical issues before this?
Why not? I mean, yeah, I underwent a surgery for my liver issues and I had some severe liver problem. I don't know actually. Probably doctor said it's something scary. So I underwent liver transplantation. Yeah.
I see. So you underwent how many years ago was that? Do you remember?
It's just 3 months, 3.5 months ago, doctor.
I see. And did they tell you exactly what it was? I mean, other than the liver being scarred, did they say, was there any particular cause for the scarring?
Any particular?
Cause? Any particular
Mm,
diagnosis?
I mean, doctor said my liver was severely damaged during that time.
Okay.
Due to my excessive alcohol habit, but then said it need to be, I mean, replaced. That's why I underwent a liver transplantation. Yeah,
Okay.
that's what
All
the
right.
surgery was
Okay.
done.
I see. And what do you smoke?
No, I used to, but I
No.
quit. I mean, 6 months ago.
Okay. And how about drinking? Do you use any form of
No, I,
alcohol?
by the way, I completely quit my drinking since my operation has been done.
Okay, good. Are you currently in a relationship or married?
Yeah, I'm living with my husband. Yeah,
Okay,
since a long
that's
time.
good.
You have 2 minutes left.
Just yeah. Okay, so I would like to examine this patient. Okay,
Yeah.
so from the edge of the bed, does the patient look grossly jaundiced?
Yeah, it looks gone jaundice. Okay, let me
Okay.
share. Okay, what you see. This is
Okay,
the
so I begin. Yes, I'm just going to look at the face first. Is there anything that I can see in the mouth?
in the mouth. No, there is nothing in the
No,
mouth.
nothing in the mouth. Anything in the palms of the hands or on the fingers?
In the
Is there
palm,
any?
there is
Yeah, I'm
no
looking for a palmar
nothing. But
erythema or any form of.
in the
Okay,
dorsal, you can see. Yeah, the palm
okay.
is fine.
And then I'm also going to have a good look at the chest region. Is there anything in the upper chest or on the
It,
abdomen that I can see other than the scar?
there
I
is
mean,
no
just
nothing. No, no, in the upper is fine.
okay. So this is a lady with jaundice, and then I'm going to palpate the abdomen gently first. So
Yeah.
upon superficial palpation, is there any obvious mass?
No, there is no
One, two,
mass.
three, four,
No,
five, six.
no, there is
Okay,
no
and how about
mass.
on deep palpation?
Yeah, there is some pain around the, I mean, belly button and yeah,
Okay,
other
at the
than
belly button region. All right,
yeah.
and I'm okay. So I'm also going to
Your
examine the
time
feet as
out.
well.
Your
Okay,
time
time's
out.
up.
Fine. I'm giving you 1 minute to complete the remaining part. Fine.
Okay, so I think that's about it actually. Is there any concerns that you have for me?
Yes, doctor. I mean, what's wrong with me? Why I'm getting, I mean, your list day by day, and is it something serious?
Okay, so from what I understand, you have previously undergone a liver transplant, okay, for
Okay.
previous liver disease. So what
Okay.
we need to think about is a potential infection, which is why you're having fever and also yellowing of the skin. So for that, we will
Mhm.
most probably you need to be admitted, yeah, so that we can treat the infection with antibiotics. And we will also need to do some blood tests and some scans or imaging to make sure we are able to find out the cause of your condition. Do you
Doctor,
have any other questions?
yeah, I mean, I'm a little bit surprised. Why I'm having these infections? You're saying something infection. I mean, I'm not
Okay.
getting what is the reason here?
All right. So the reason why we suspect that we need to make sure that there's no infection is because it's because of the fact that you have fever, and then you did mention in when you were telling us that you
Time
had
up.
some
Okay,
chills.
fine.
Yeah.
Time up.
Okay.
So, Dr. Lee, can you present your positive findings from history and examination.
Okay, so this is actually a 65-year-old lady whose presenting complaint was jaundice associated with malaise and also fever with chills and rigors. So her medical history is also significant for liver transplant for what was considered to be cirrhosis. In addition, the jaundice was also associated with pruritus and also with loss of appetite. So tying
Okay.
in all together,
Mhm.
all right, tying it all together, this lady, the age group of this lady and the presenting symptoms are more in keeping with a primary biliary cirrhosis or PBC, in that she also has features of cholangitis. In addition, I would like to make sure that she's not having sepsis secondary to ascending cholangitis, because she also has jaundice associated with chills and rigors as well as fever. My other differentials in her case, given that she is of this particular age of 65 years old, is
Okay.
viral hepatitis, which is complicating the post-liver transplant, or
Mhm.
recurrence of PBC in a patient who has already undergone liver transplant. I
Okay.
mean, the recurrence of PBC in a patient who has undergone liver transplant for possible PBC before this. Yeah.
Okay. Okay. Fine. So you say that could be post-transplantation infections. Can you specify or be a little bit specific what could be the underlying cause of organisms or that you want to say here?
Oh, that's okay. So, post-transplant, I mean, it's not an immediate post-transplant infection, but rather an infection that she acquired many years later. For example, commonly in this part of the world will be viral hepatitis. We will need to make sure that there's no, we will need to work her up for any cause of fulminant viral hepatitis leading to this, to her cause of jaundice as well as fever.
Did you
Right?
find any cause that can cause fulminant hepatitis in
Yeah.
this patient?
So for her case, I ideally would have asked for a travel history, but I forgot. So
Mhm.
most probably I would need to make sure that this is not hepatitis A, because it can present similarly, fulminantly.
Mhm.
In addition, the other commoner viral hepatitis, but with less fulminant natural
Okay,
histories, would be
fine.
hepatitis B
You
and
t-
C.
okay,
Yeah.
fine. Mhm. So, how you want to investigate these patients to confirm your
Okay.
diagnosis as well as exclude your differential?
Yes. Okay. So first of all, so first of all, I would like to first admit this patient, and the investigations I would like to order would be on the full blood count. So
Mhm.
on the full blood count, because I'm thinking of an infection, I'm actually paying attention to the white cell count, where I'm going to expect neutrophilia if it's a case of bacterial infection, or
Mhm.
lymphocytosis if it is indeed viral in nature. I would
Mhm.
also be looking at the hemoglobin to look at the so if the hemoglobin is low, indicating anemia, I'm also going to look at the MCV and MCH. So this will let me know whether this is a long-standing issue, a chronic issue, or is it of an acute issue. In addition, I'll be looking at the coagulation profile to look for the synthetic function of the liver. So if the PT and the INR are both deranged, then it means that not only does she have an infection of the liver or
Okay.
hepatobiliary tract, there's impairment. I'm also
Okay.
looking at the liver function test, and
Mhm.
also the viral screen for hepatitis B and C. And
Mhm.
if I'm able to send for hepatitis A IgM serology, I would send that as well. And finally,
Okay.
blood cultures and CRP. Yeah.
So, Dr. Lee, do you think anything in this patient particularly who underwent a surgery a few months back? Do you think about any particular investigations or anything more? If
Uh,
I ask you, yeah,
any particular
investigation.
investigations?
That
Okay.
is, okay. But you're thinking about viral hepatitis A, and few other things. Fine. Okay, we'll discuss later. So, how you want to manage these patients, considering patient symptoms and overall history, and what the findings you got?
Okay, so actually, I'm thinking that she has a recurrence of, I mean, she has ascending cholangitis. I mean, I'm going to manage her for ascending cholangitis in addition to recurrence of primary biliary cirrhosis post-transplant. So
Mhm.
the first half of the treatment would be targeted towards the acute management. So we'll be putting her fulfilling the sepsis 6 bundles, the intravenous fluids, and also antibiotics to target the ascending cholangitis. And
Okay.
also maybe we will need to discuss with the general surgical team, or in this case, the hepatology team, to arrange for an
Time up.
emergency. Yeah, thank you.
5 minute crossing. Time up. Well done. Okay. So Dr. Lee, how does it goes to you, according to you?
I think it definitely has a lot of room for improvement. Definitely.
No problem. No problem. We are all practicing here. Anything you could have done differently if you given the second chance or second, way? Anything you could have done differently?
Let me see. Actually, I would have paid more attention to the indication for that liver transplant, and
Mm-hmm.
also the let's see, what was I talking about? Yeah, the indication for the liver transplant,
Mm-hmm.
and
Okay, fine. No problem.
yeah.
Okay,
Mm.
let's discuss the case before, going to give the complete feedback on your performance, your positive side, your negative. Then, would like to take the comment from other people because this is very interesting high yield case, very common case, and there is high degree of chance it may come in the, again in the second or third diet. Okay, so let's have some comment in the comment section, or you can unmute yourself and can put some differential. Yeah. Anyone has any
If the
comment?
patient is now on any immunosuppressive therapy after transplantation, then there
Yeah,
will be
Dr.
a chance of.
Lubna, I'm not hearing properly. Can you just raise your voice or microphone a little
Okay,
bit closer?
Bhaiya, yes,
Yeah.
as the
Uh,
patient is just got transplantation 3 months before, and now maybe she is on immunosuppressive therapy. That's why there could be a chance
yeah.
infection
Mm, yeah.
like
Right.
cytomegalovirus infection. That's why we could ask her about the drug history, kind is need on a drug or
Yeah,
not.
I
And
got the point. Post transplant infection you're trying to say, right?
yes, yes.
Okay,
I
fine.
um,
Mm-hmm.
the
Continue.
indication of transplantation. There more indication of transplantation was needed.
Mm-hmm.
The patient didn't mention a lot about the indication. Uh, uh, our participant is explaining that there could be a chance of recurrence of primary biliary colon cirrhosis, right?
No,
Of
I did not say
primary
that.
sclerosing cholangitis.
As a patient, I did not say any pre-existing condition. So I would say don't assume something that may trap you in the real exams. Okay, fine. We'll discuss that.
Okay.
Anything, do you think any in the investigation part you want to add along with Dr. Lee already what he said?
Liver function test in details.
He said that. Yeah, in detail.
Okay.
Okay, no worry. Fine. Fair enough. We'll discuss the case. Okay. Anyone has any other differential? Because I just want to discuss the case in detail. Just before that, I am interested to take your opinion. Okay. Autoimmune profile is very important. Okay, Dr. Abbas, thank you for putting here. Okay, fine. Okay, fine. Well done, Dr. Lee. I was very happy. First of all, I'll give the some positive things, but you did very well. Okay, so your starting was very fine with clear approach. You asked about my name and full name, and then how to create and what presenting features or causing the problems. Your analysis, symptom analysis was very fine, but I would say for the time purpose and LCC purpose, it was a little bit more detailed. You have to be sleek enough as you have to cover a lot of things. Okay, so I would say patient presented with Eury's discolorations. Okay, so yeah, to get a better idea, you can ask few questions about the tummy and loose motion, but don't dig deeper about the loose motion issue, how much, how frequent, how color, how content, because it will not add the ultimate value of your diagnosis. Yeah, there's some missing point will be there in this kind of long scenario, but I would say it is better to touch all the scale, all the points, okay, so that you can get marks at least without missing complete one skill completely. Okay, that's my recommendations. Okay, So you took the detailed history about the loose motions. That was very fine, and the pain history. Okay, and at one point, I'm guessing okay, you already got the diagnosis, but when you take the, I mean, past history, I said it from myself. As time is running out, I'm raising it from my side, but when you are not getting any things in particular, in the first 4 or 5 minutes, I would say everyone go for PDF, past medical history, surgical history, family history, drug history, because in most of the cases, if prompt is not giving any clue, you should dig deeper into these three sections, because in most of the cases, the key will be lie here. You have to dig deeper. Have a past medical history, surgical history. As this patient already said, I have undergone a surgery. You have to dig deeper into the surgery. For which indication he was underwent surgery? Did doctor say any particular diagnosis? What medication? Doctor leave you miss the medication chart completely. And I'm pretty sure if you ask about the medication, probably I would say I'm taking metrophenol, tacrolimus, and cyclosporine. And you probably get some good clue that can justify the loose motion at the same time you lose discoloration and tummy pain. Yeah, but I noticed that you connect these three symptoms, pain, fever, and abdominal pain, that, I mean, I would say bias you to think about the primary sclerosing cholangitis, okay? And you assume that a patient might have in past primary sclerosing cholangitis, which is, I mean, recurrently appearing in this patient. This was completely your assume part, but I did not calibrate this case in that. And if you ask me about the drug history, probably you get a very good clue. So that's why when you are not getting any particular clue for the case, touch everything. Go for the past medical history, surgical history, family history, drug history is very important. Is there any recent change in the drug or medication? Fine. In a liver case, there are few important points will come automatically and should come, I mean, automatically. Any IV medication? What about the drinking habit? Any blood transfusion? Any herbal medications? And sexual history. Although this patient is very elderly female, still we have to ask that, and Dr. Lee asked about the partner. That was very fine. Okay. But in any liver case, in Indian center, the examiner is wait for three things: any IV blood abuse, any blood transfusion, any sexual intimacy or exposure apart from the marital, okay, and herbal medication. So these three is very important. And by the way, in real exam, they will not calibrate everything, but if you ask, they will say no, no, no. So ultimately, you will, I mean, collect the point, which is very important. And history part was a little bit longer. I know the situation demand, but for the sake of, I mean, LCC, as you have to touch 7 skill, I would say compromise 1 marks from the history part. Don't hope for 4 marks. In some situation, it is better to omit something than commit. Why? If you meet, I mean, fail to meet the concern, you will get 0 from the concern. Better, you should satisfy with 3 marks from the history, then rest of the 3 from the other part, and meet the concern excellent, where get the 4 marks. So ultimately, it's not bad to end up with 24 or 25 in this type of long scenario. Rather, you are, I mean, firstly taking all history all the time run out, you are rushed to do the examination, then ultimately you will fail to meet the concern. So I would say PACES is all about balance, how you want to play the game. When you know this is a big tournament, big case, I have to omit something, because I don't want to miss the basic examination step. I don't want to miss the concern part. Probably will get very good marks in the that part. Okay, so that's one of my, I mean, suggestion, not suggestion, I would say recommendation. Dr. Lee, your history taking was very fine with clear voice. Everything is very clear in a finer way. But I would say make it concise, make it a little bit quick. Okay, so that you can touch a few other things. And in terms of impact, it was completely missed. Although patient is homebound, probably dependent on her husband, still examiner will look for that, how it is impacting their daily lives. and I will show you the marksheet later on. Okay, so come back to the history part. And one diagram I noticed, sorry for being harsh, an examiner or a mentor this time, you said urine, so it should be water wax, okay? Water wax. Fine. When I say, doctor, I have pain and it's increasing, you said good. No. So we should appropriately use the good and okay. Okay, sometimes we use default word okay. It should be, limited. Okay, when you will say okay, when patient is saying, I'm in a painful state, examiner may mind it. Okay, so I would say a little bit conscious about that. In terms of history, that was the, missing point, and smoking and alcohol was asked. That was very fine. In the examination part, I think your examination was fine. You covered most of the things. Started with the hands. In the hand, we should check about also tremor. Although you, probably in the real exam you will check it, but checking the tremor is important as tachypnea can cause it. Okay, checking the hands both part to see any pigmentations present or not, or jaundice is there. Then we have to check the mouth cavity very well. You check it to see what? To see any oral sore, any gum hypertrophy, okay? And at one point you said, did you notice your hair is falling? I said, no, doctor, rather I'm noticing my, previous history of, hair and fall has been done. It means hair is growing or probably hair loss is, stopped due to cyclosporine. Cyclosporine sometimes causes excessive hair growth along with the facial lines and few other mustache area. Okay, so that is the subtle clue I gave you. Then we can check about the tummy. As the trauma is around the tummy, we have to check tummy. Patient has some pain, so we have to palpate the all quadrant. Along with, we have to demonstrate the examiner that you notice the scar very well. You have to draw your finger with the proper permission. That do you have any pain? You have to draw like this. Do you know why? Because you notice the scar, which is well healed, and you have to demonstrate the examiner that you noticed it. Okay, otherwise, examiner may mind, okay, and they will cut the marks that you did not notice it. Okay, so I will say when any scar during PACES exam you're getting, it is not painful. Draw your finger over the scar. It means you are drawing the attentions, you noticed it. At the same time, you will get some time to recollect your thought of what will be your next move. What part you will examine the next. As patient said, loose motion, probably you get some idea. It could be post.
Please, scar over the patient.
Sorry. Scar. This is the Mercedes-Benz scar. This is the Mercedes-Benz scar, which is very prominent here. There is some, a tree angle, right? Tree, I would say this is the rooftop, and along with the extensions in the mid-stem area. So this is the Mercedes-Benz scar, and which is very prominent and very, popular for liver transplant. So this patient underwent liver transplant, already said that. For which condition, we don't know, but in the history part, we should ask about for which condition you underwent this surgery. Okay, then in the pedal area, in the lower limbs, we should look for few other things because patients probably on some number of immunosuppression. There might be steroid stria, right? There might be some redness or stria. There are some pedal edema or just puffiness, okay? Or some obesity could be there. It's just a general look. You have to, check it, okay, in the pedal area. Then when any patient presented with loose motion, it's a default offering. I would like to check the rectal area. Okay. In the PACES exam, you have to offer it. They will not, give you the permissions, but any patient presented with hematemesis, melena or diarrhea, you have to check the rectal area. You have to offer it. Okay. So this is the calibration in this case. Okay, now coming to the differential. Yes, One of the differential Dr. Lee said the post-transplant infection. I took it fine. That was your second differential, but the first differential was primary sclerosing cholangitis. I don't know why you assume that, because I did not say it from my side. So I would say, don't, assume something, rather use the broad, terms, which will cover your differential. For example, in this case, this patient had jaundice, post-transplant jaundice. Due to what? Due to could be drug or some opportunistic infection. As patient has diarrhea, along with some tummy pain and fever, so I might suspect this patient's suffering from some opportunistic infection, post-transplant opportunistic infection. It could be cytomegalovirus, which is also called hepatotrophic virus that causes jaundice. It could be Epstein-Barr virus. Okay, it could be other opportunistic infection. Okay, if the patient has, just in this case, has some lumps and bumps in area, there is no diarrhea, the diagnosis still will be confined with the post-transplant lymphoproliferative disorder. Okay, and to confirm the recurrence, we have to be much more confident about the pre-existing condition, because we don't know for which conditions this patient underwent surgery. Okay, and another condition could be autoimmune. Considering female S, yes, you can put it, but not in the first and second position. Yeah. So Dr. Lee, are you with me? I'm
Yes.
actually saying a lot. Okay. So this is, yeah, let's have my calibration, what I put in this type of scenario, what should be our focus examinations and what we can do. And one thing I also say, always offer something. When your time is running out, at least you can offer something as a default. Blood pressure, blood sugar, urine dip. Why? Sometimes it may work with your scenario, sometimes not. But in most of the cases, directly or indirectly, your offering will work well. How? For example, in this case, if you look the blood pressure and blood sugar, you will not get the miss or miss the mark. Probably patient has dehydration due to loose motion, has some postural drops. So offering blood pressure sounds good, okay, no problem. Blood sugar, why? Patient probably on steroids, so we can get some idea about the drug-induced diabetes. Blood urine, urine. By checking the urine, you also get some idea. Drug level could be fine in the cyclosporine level or tacrolimus. It could be by checking the blood or urine. Even in the urine, if there is any other, infections or whatever I would say, by routine check, you can do it. Okay. So there are a few things we can offer in any LCC case. Okay. So in a post-liver transplant patients, there should be few things we should look for. Is there any opportunistic infections or any, infections anywhere of the body? Patients might have some pedal infections or tinea in the groin or few other area. Pigmentation might be there. Just look for, inspection is very key. There could be some ulcer in the shin area due to diabetes. Okay. Although in this calibration was not there, I'm discussing the case in general. Okay, tremor, which is very important. It could be due to hepatic flap, for example. It could be due to drug effect. Tacrolimus, T for tacrolimus, T for tremor. So it could be due to two conditions. Okay, so checking the tremor will create some good impression in the face of examiner. And a scar in the epigastric and subcostal area, look for that. Okay, so this scar is very important. And when you examine everything, just offer for a few things, which is very important. Blood pressure, blood sugar, urine drip, I already said that. Then drug level. I would like to check the detail, a drug history. You can ask in the history part, in the monitor section, but you also offer, okay, I would like to check the drug he is taking, because patients might have taken number of medications. Okay. So in that case, it is better not to ask for that. I would like to check the whole drug list they will give you. So if they mention one by one, it will cost you time. Okay. And fundoscopy, according to writer and different books, they also say any patients in a case of kidney transplant, in that case, fundoscopy, not in the liver case. Okay, fine. For the sake of discussion, I'd like to share a few other things. For example, this patient has right iliac fossa scar. Yes, in that case, you can think about it could be primary sclerosing cholangitis. Why? As a part of ulcerative colitis, it may come associated with primary sclerosing cholangitis. So probably this patient previously underwent surgery for ulcerative colitis. You can get some idea. If there is any scar in the right iliac fossa, if there is any scar on the left iliac fossa, it could be ulcerative colitis. Sorry, in the right iliac fossa, it could be due to Crohn's disease. Okay. So this is very important. I mean, parallel looking and looking as a whole is very important. For example, these patients, if you look at that, it was in my calibrations. Okay. For example, patient has a tracheostomy scar is there, just as you, along with some liver transplant. We should not be panicked. Probably following surgery, patients underwent in critical care unit. Okay, during that times, he or she underwent some tracheostomy scar. There could be some drain tube scar is there. So look for in a broader view so that we don't get panic. Okay. Now coming back to the situations, okay, what could be the few other things in this type of scenario? If the patient has liver scar with right iliac fossa or left iliac fossa, in that case, liver kidney transplantation could be another possibilities. Patients with paracetamol poisoning, in that case, kidney may be involved. So there could be concomitant, okay? Scar is there. So we have to take the detailed history just for the sake of discussion. Patients might have adult polycystic kidney disease. In that case, the liver cyst, mucocirrhosis, and kidney transplantation in the one side. So there might be a long scar, okay? And which may indicate the kidney, liver, transplantation. Patient might have diabetes, okay, type 2 diabetes. Now patient underwent a surgery. So kidney pancreas transplantation scar might be like this, okay? It's not typically the muscles, but lower down through the umbilicus, okay? It looks like the same, That's why I just noted here. Fine. So these are the things. And checking the lymph node, I noted down. Checking the lymph node in post-transplant patient is very important, as one of the complications of the post-transplant lymphoproliferative disorder that could happen. And patients might be presented with the same type of features like fever, weight loss, lumps and bumps in the neck area, and night sweat. Okay, all of the symptoms of the lymphoma will be present, just along with past history of liver transplant. Okay, so just taking few history, if I say in a nutshell, when patient underwent liver transplant, full history you should take it. If there any tummy pain, any loose motion, any lumps and bumps, any night sweat, okay, as any pigmentations, any tremor, any high blood pressure, and high blood sugar, any hair growth. If you take these 4 or 5 questions, you will get all the side effect along with some other manifestation of the post-proliferative disorder and few other things. Okay, even post-transplant patient may present with some herpes or zoster, okay, due to opportunistic infections. There is propensity to develop easy infection. So what are the things? Okay, so the relevant things might be asked and come in these equations in this type of scenario. What are the indication of the Mercedes-Benz scar? Liver transplant, in this case, resection of the left lobe, repulse operations, esophagectomy. This type of crossing questions they may ask in their crossing part. So it is better to know that. And they can ask about, okay, what are the AN stage CLD, causes of CLD. You already know that chronic alcoholic liver disease, viral, non-alcoholic, and autoimmune. In this case, yes, autoimmune is a good chance to come forward as patient is female, but we don't know. So we have to say most common cause. Patient say that I was very alcoholic, okay, extreme alcoholic. So probably this could be the top one. So what are the DD? I already said that. What are the investigation panel? In my calibration, I was expecting drug level. As patient is on some immunosuppressant drug, histology, examination, ultrasonography. This is the most key, most important investigation panel in this case. Apart from the liver screening, viral screening, autoimmune screening, you can do it. But checking the sepsis screening, Dr. Lee mentioned that was very fine. Checking them for the sepsis screening, autoimmune screening, and stool RE, which is very important, and drug screening. In my Pune center, I passed from the Pune. They said me one investigation you want to do in a post-transplant patient. What would be? They asked in the same way, you should say post-transplant, patients taking post-transplant number medication, right? So I will go for drug screening. That would be my number one investigation. Then I will go for ultrasonography, how the organ is working. Is there any problems or not? Any graft rejection? So this case, I'm again go back to the scenario. This case could be another possibilities of the acute graft rejection if there is any tenderness in the scar area. You can justify all of your symptoms, loose motion, fever, tenderness, jaundice. If there is any pain along with this, line. So that's why it is very important. With the proper permission, I am drawing my finger along with the scar line. You will get some idea. An examiner will note it. Okay. If there is any tenderness, there is graft rejection. In that case, you have to do whole liver screening along with ultrasonography. Okay, color Doppler to see vascular patency as well, along with full screening, sepsis screening, autoimmune screening. Okay, everything you have to do. Now, I'm going back. Inflammatory marker will be there, urinary is there, and colonoscopy. I don't know why yes, due to diarrhea. Due to diarrhea, I collected this information, colonoscopy, from one of the feedback. The candidate passed from the Pune. The scenario was that, and there's mentioned in the feedback part, when any patient presented with post-transplant diarrhea, colonoscopy is a must. They mention in that way. They take the investigation colonoscopy. You have to do the colonoscopy. Why? Patient might have some post-transplant lymphoproliferative disorder, even in the gut level. Okay, so they mentioned the colonoscopy is there. And HbA1c and random blood sugar checking is very important, as steroid can cause. Okay, so UNDP I already said that. Renal function test. What are the treatment? Non-pharmacological treatment will be the same: education and counseling, nutrient buildup, and alcohol cessations. Already patients stop that. But regular follow-up is very important, and monitoring the drug level. That actually the management. And Dr. Lee, excellently said, contact with the transplant team. They wait for these terms, okay? So when any patient presented following transplantation, as a doctor, we have to assess, and followed by, we will connect them with the transplant team. And transplant team will do the rest of the things. They will evaluate other things and okay. So management broadly directed to the underlying cause. In this case, according to my calibration, this was post-transplant opportunistic infections. Probability it's cytomegalovirus induced colitis or hepatitis, and Epstein-Barr virus. So I would say in the PACES, it is better to use the broad term, post-transplant opportunistic infection. If there is any lymph node is there, the whole scenario may turn into post-transplant lymphoproliferative disorder. Okay. So I don't know, Dr. Lee, have any questions from your side? Are you with me?
Thank you for the case. So, so for this type of scenario, let's say if I offer, because when during the exam, they ask you what's your main differential and what are your other differentials. So if I were to say my main differential is, for example, post-liver transplant opportunistic infection due to immunosuppression, and then if they ask me what other differentials I can add on, like to make up 4 or 5 differentials, so could I say things like maybe he's having some ascending cholangitis or some viral hepatitis, just to make up the differential list of at least 3 to 4?
Yes, I got your questions. Fine. So
Yeah.
you have to play the diplomatic game. Yes, you will say the same things. It could be recurrence of the primary disease. You would not say specifically this is primary sclerosing cholangitis. Yes, it might be
Yes, correct.
underwent for that, but I'm not sure, and patient did not say that. So what I can do, think about the patient's condition. Patients might have some condition again back. So I would say recurrence of the primary disease. I would not say is it autoimmune hepatitis, is it primary sclerosing cholangitis, or is it primary biliary cirrhosis, because I don't know. Even patient did not say that. If patient say during the history, doctor, I was suffering from primary sclerosing cholangitis, I would say in that situation or condition, your differential definitely valid. As patient is completely unaware, he did not mention anything, so I would say recurrence of the primary disease would be the most appropriate term. Not very specific, but it would cover almost every condition. Did you get my point?
Yes. Okay. Very clear.
Okay. So, yeah, the most two differentially in this case, post-transplant immunosuppression induced opportunistic infection, then recurrence of the primary disease, and then you can say simply viral hepatitis. These are the three conditions again in this case. So few other things is very important relevant to this scenario. They may ask about what are the primary, most common complication of the immunosuppression. Well, I usually prefer to make mnemonic so that in the exam setting, under the exam pressure, okay, you can come up with some rapid answer. Okay, so metabolic disease as there hypertension, hyperlipidemia, post-transplant diabetes, post-transplant anemia. Okay, these are the metabolic disease I collected from the Rupa version. And malignant disease, there are few conditions: solid organ tumor, post-transplant lymphoproliferative disorder, skin malignancy, non-melanoma, right? And morphological change, Cushingoid appearance, acne vulgaris, hirsutism. I already said that, and that's why I said, Doctor, my hair tend to fall before, but right now it stopped. It means there's some hair growth. Okay, so gingival hyperplasia, okay, which can be detected by opening the mouth. Check the gum actively in this type of scenario. And lastly, chronic transplant injury could be so due to cyclosporidium and tacrolimus. Now I have some quiz for you. Okay. Before going to the quiz sections, I would like to share a few other things. These are the commonly asked questions in a transplant case. Okay, for example, they will say, what are the commonest indication of the liver transplant? According to the, prevalence and incidence in the UK, alcoholic liver disease is the most common. So you have to say that. Then considering patient age, female gender, you can say about autoimmune. Yes, but alcohol should be the first. Is liver transplant is indicated in CLD due to chronic hepatitis C virus? This was one of the questions I collected from the feedback. That's why I put it here. Yes, liver transplant is indicated in CLD due to hepatitis C virus. Overall survival rate, about 60% patients who underwent surgery, they can live normal life up to 5 years. Okay, so just remember it. And this is some advanced rare questions, not always needed, but better to know. What are the type of liver support you can give in a liver transplant patients or liver damage patient? Okay, molecular assisted reticular system, recirculation system, extracorporeal liver assisted device, heterotrophic liver transplantation. So these are the, common question they ask in the exam. But most common is coming the next slide. What are the indications? They will invariably ask in a liver transplant patient. What are the common indications for liver transplantation in a liver unit? Okay, so paracetamol related indication is there, non-paracetamol related indication is there. So I prefer you can remember one part and rest of the part you will remember in any other way. Paracetamol related indication usually follow the rule of 3. 7.3, lactate more than 3.5, when lactate more than 3 up to 12 hours, or there are 3 of any features. Grade 3 hepatic encephalopathy, creatinine more than 300, okay? So you can remember in your way. I would say just make it simple. Okay, 2 or 3 indications is important. If you remember the other, that's fine. Okay. Now the slide is waiting for you. What are the scenario related to the post-transplant patients? Okay. So patients, post-transplant patient, now weight gain, bone pain, frothy urine, fatigue. What you will consider? Anyone? Unmute yourself and come up with your answer. What would be the diagnosis? Patient underweight?
It could be Cushing syndrome.
Okay. Let's see what. Okay. Just
Iatrogenic Cushing, drug induced.
Just fine. Let's see what is waiting for us. Post-transplant diabetes mellitus or Cushing. Yeah, Cushing is fine. It is accepted as patient has some weight gain issue, but more goes with the post-transplant diabetes mellitus only because there is no other issue of muscle weakness or striae. Just say frothy urine, bone pain, okay, and fatigue. Yeah, Cushing definitely could be a good difference. Yeah. So post-transplant, weight loss and loose motion. In this case, what we just discussed few minutes ago. In that case, this is opportunistic infection in the gut, cytomegalovirus colitis. Dr. Lee said that. Okay. Then post-transplant patients with weight loss, fever, itchy skin. Can anyone say what could be, Dr. Lee?
Skin malignancy.
PTLD.
Okay. I would like to get few more comments. Okay.
Recurrence of primary disease.
Weight loss, fever, itchy skin. Like, okay, let's see what I put here. PTLD, okay, post-transplant lymphoproliferative disorder. There are a few clues here: weight loss, fever, itchy skin. I did not give the night sweat. If I give night sweat, then you will catch it very easily. And the real exam, they will not give everything, okay? But every symptoms it goes favor with these symptoms. So you have to think about the lymphoma, post-transplant lymphoma or lymphoproliferative disorder. The last one for our today's session. Can anyone say post-transplant weight gain, body swelling? This is the Cushing. This is the Cushing, okay?
Yes,
or
correct.
Sorry, or probably the transplant is not working. Transplant is not working. I probably mess up with few things. Body swelling, not weight actually. It actually the tender scar. I probably forget to edit it. Yes. If the patient presented with post-transplant, there is some tenderness on the scar area. Body swelling means retention of the fluid. It can be
Is this due to
happen
renal
with
transplant or
renal transplant. It could be liver and renal, combined liver and renal. That's actually I put it here. I would cover the whole transplant theme. That's why I put it here. So when patient underwent liver and renal transplant, in that case, the kidney transplant is not working. So fluid is accumulating and giving the impression of whole body swelling. So it means transplant is not working. In case of liver, the feature almost similar. Post-transplant patient, now deep color jaundice. There is some tender area on the graft area. In that case, you can think about the graft rejection or graft is not working properly. Okay, if it is within the 6 months, usually we say acute. Then 6 to 1 year, probably this is chronic. Okay, so these are the broad terms we can use. And any graft rejection failure can be elicited in a very good way by doing an ultrasonography. Okay, we can easily see the vascular patency, any clot, any stricture, okay, any thrombus in a renal transplant as well as also liver transplant. So ultrasonography should be investigation modalities and panel in your investigation channel. You have to mention it. and relevant organ-related investigation. Full liver screen in case of liver, full renal function test in case of renal transplant. If there is any fever, one investigation by default will add sepsis screening in case of liver, in case of renal. If there is any autoimmune disease, autoimmune screening in liver case. Okay. Then finally, complete blood count, inflammatory markers, CBC and ESR. And drug screening in both cases will be common. So if you just read in this way, what is common and what is the difference, both transplant cases will be very easy for you. So I don't know anyone has any questions or comment.
Doctor, third one here for what post-transplant patient with loss of fever which is skin. This for what?
Yeah. Post-transplant lymphoproliferative disorder, patients might have some lymph node. I did not give this clue here. You have to elicit from your clinical examination. Okay. So when post-transplant patient presented with fever, weight loss, and some itchy skin, definitely these three are B symptoms. So you should look for any lymph node anywhere. It's going to be, post-transplant lymphoproliferative disorder. Okay. But when any loose motion, your complete focus should be changed. It could be opportunistic infections like cytomegalovirus or Epstein-Barr virus. If there is any bone pain, bulky body, diabetes mellitus, fatigue, you should think about Cushing and post-transplant diabetes mellitus. Okay. If there is any herpes zoster or frequent infection, opportunistic infection. Just think in this way. Yeah. So thank you for joining, and hopefully see you soon in the next session. If you don't have any questions, we can conclude the session for today's night. Is there any question? Dr. They asked the cold position leakage thrombus post-transplant. Yeah, drag on the background of PPC. Okay, thank you. See you soon.